Hi everyone, welcome back to our fifth video of the lecture. In this video, we will continue the glucose lowering agents to treat the type 2 diabetes mellitus. In this video, we will cover another four groups of glucose lowering agents, which are the alpha glucosidase inhibitors, DPP4 inhibitors, GLP-1 analog, and SGLT2 inhibitors. The fifth glucose-lowering agent is alpha-glucosidase inhibitors. Complex starch, oligosaccharides, and disaccharides must be broken down into individual monosaccharides by alpha-glucosidase that present on brush border of the intestinal cells. Alpha-glucosidase enzyme consists of sucrase, maltase, glucoamylase, and dextranase. The only monosaccharides, which is the glucose and fructose, can be transported out of the intestinal lumen and into the bloodstream. Acarbose and blegiritol are competitive inhibitors of the intestinal alpha-glucosidase. It will reduce the post-meal glucose excretion by delaying the digestion and absorption of starch and disaccharide. Is able to reduce HbA1c up to 0.8%. The most common side effects are flatulence, diarrhea, abdominal pain, and bloating. The next glucose-lowering agents that we will cover are DPP4 inhibitor and GLP-1 analogs. Sitagliptin, sazagliptin, and vildagliptin are inhibitors of dipeptidyl peptidase 4 enzyme. This enzyme degrades the incretin hormones such as GLP-1 and GIP within few minutes. The binding of this drug blocking the DPP4 activity, in which will increase the circulating level of native GLP-1 and GIP, which will decrease the postprandial glucose excretion by increasing the insulin level in the blood. GLP-1 analog is up to 96% mimic to our body GLP-1 structure. Liraglutide, exenatide, and lizisenatide are among the FDA approval of the GLP-1 analog drug. This drug is administered subcutaneously. The presence of this analog in the blood system will not cause any degradation by the DPP4 enzyme. Sitagliptin and sazagliptin are the DPP4 inhibitors that can achieve peak concentration over 85% within 1 to 4 hours and can be last approximately about 12 hours. It is primarily excreted via urine and metabolized primarily by cytochrome 3A4 isoform. The metabolite of sitagliptin is inactive metabolite, which contrasts to sazagliptin that form active metabolites. The dosage should be reduced in patients with impaired renal function, and the dosage adjustment is recommended to those who concurrent use of strong cytochrome 3A4 or 3A5 inhibitors such as antiviral, antifungal, and certain antibacterial agents. Sitagliptin can be given as monotherapy or in combination with metformin, sulfonylurea, and thiazolidinedione. Therapy with DPP4 inhibitors has resulted in HbA1c reduction of 0.5 up to 0.8%. Hypoglycemia can occur when the drug is combined with insulin secretagogues such as sulfonylurea and metaglinide, or also they combine with the insulin therapy. Thus, the dosage of concurrently administered insulin secretagogue or insulin therapy may need to be lowered to prevent the hypoglycemia incident. The drug should be immediately discontinued if pancreatitis or allergic and hypersensitivity reactions occur. Sazagliptin may increase the risk of heart failure, especially to those who had history of heart failure or had renal impairment. As you can see here in GLP-1 analog, Exenatide has a 53% homology and liraglutide has about 90-70% homology with native GLP-1. The glycine substitution in the native GLP-1 able to reduce degradation by DPP-4 enzyme. This GLP-1 analog is injected subcutaneously within 60 minutes before breakfast and also before dinner for exenatide. It reached a peak concentration in approximately 2 hours, with the duration of action can be up to 10 hours. In contrast, liraglutide has once daily dosing due to the half-life approximately about 12 hours. If exenatide or liraglutide is added to pre-existing sulfonylurea therapy, the sulfonylurea dose needs to be decreased to prevent any hypoglycemia incident. Exenatide monotherapy or combination therapy can result in HbA1c reduction up to 1.2% and can be up to 1.5% using liraglutide. Weight loss in the range of 2 to 3 kg can occur, and it will contribute to the improvement of glucose control. However, all of the GLP-1 receptor agonists may increase the risk of pancreatitis. Patients on this drug should be counseled to seek immediate medical care if they experience any unexplained persistent severe abdominal pain. The last anti-diabetic drug that can be used in type 2 diabetes is the SGLT2 inhibitors. Before we go further, the SGLT2 can present in the proximal convoluted tubule. This presence of the SGLT2 will cause 90% of the glucose reabsorption into the blood system. Thus, this SGLT2 inhibitor reduces the reabsorption of glucose and also sodium in the renal tubules that will lead to the glycosuria and natriuresis. Currently, there are 3 SGLT2 selective inhibitors that already be approved by the FDA for mono, dual, and triple therapy. Canagliflozin, dapagliflozin, and empagliflozin are the SGLT2 inhibitors. These SGLT2 inhibitors lowers the glucose level by changing the renal threshold and not by insulin action. As mentioned earlier, the inhibition of the SGLT2 transporter will cause glycosuria and natriuresis, which will be useful option in obese and hypertensive patients because of their weight loss and anti-hypertensive benefits. As you learn later in the BHC 615 cardiovascular system, less sodium level in the plasma will prevent sodium and water overload, hence be able to reduce the blood pressure, myocardial stretch, as well as increase the tubuloglomerular feedback, which can reduce the intraglomerular hypertension and reduce the hyperfiltration. Patients who are at high risk for hypoglycemia may benefit from a combination of metformin and SGLT2 inhibitors because the risk of hypoglycemia with SGLT2 inhibitor is small when compared to insulin and sulfonylurea. It is because their action is independent of beta cell function, which the beta cell function will lead to insulin secretion. SGLT2 inhibitors are contraindicated for patients with renal insufficiency with GFR rate less than 45 ml per minute. They are cardio and renal protective and not used as treatment for renal failure. SGLT2 inhibitor is indicated as a monotherapy or as a second-line therapy in combination with metformin. SGLT2 inhibitors able to decrease HbA1c by 0.2 to 0.5, 0.8% with monotherapy. However, glycosuria effects of SGLT2 inhibitor may induce myocardial infection in the genital area. Besides, it also may cause orthostatic hypotension due to the volume depletion and osmotic diuresis. Here is the algorithm that used as a guideline to prescribe anti-diabetic drugs in type 2 diabetes. The newly diagnosed type 2 diabetes will be requested to change their lifestyle by increasing their physical activity and optimize their daily nutrition intake. To those who have HbA1c in the range of 6.5% up to 7.5%, they will receive monotherapy from this group of class. Metformin will be the most preferred drug used to treat type 2 diabetes mellitus unless it is contraindicated, especially in the renal failure patient as mentioned in the previous video. If the patient unable to achieve the desired target goals even though the dose of metformin has been fully optimized, we will consider the dual therapy by adding another class of anti-diabetic drugs as stated here. To those who are newly diagnosed type 2 diabetic patients, whose the HbA1c in the range of 8.5% up to 10%, or the fasting plasma glucose in the range of 10 to 13 millimole per liter, we will straight away given him or her triple therapy of metformin and another two class of anti-diabetic drug as stated here. As mentioned in the previous video, insulin therapy is given to type 1 diabetic or type 2 diabetes who are newly diagnosed with HbA1c more than 10% of the fasting plasma glucose more than 30 millimole per liter. To those who already achieve full optimized of triple therapy and fail to achieve their desired range, the insulin therapy should be initiated.